So our speaker today, Dr. Laura Fanucchi, is the board certified physician in internal medicine and addiction medicine. She provides treatment for opioid use disorder in the UK Blue Cross Care Clinic and in the UK First Bridge Clinic. Dr. Fanucchi's research focuses in integrating evidence-based treatment of opioid use disorder in medically complex patient populations. She has presented regionally and nationally on the management of hospitalized patients with opioid use disorder and provides trainings to physicians and other members of the healthcare team. Dr. Fanucchi is also a co-investigator on the treatment team of the Healing Community Study. So thank you, Dr. Fanucchi, for being here today.
Hi, everybody. Thanks for being here this afternoon. So I'm realizing I'm too far ahead. Here we go. Okay. Okay. I don't have any financial disclosures to share. So the practice gap and educational needs for this session. Less than 20% of people with an opioid use disorder receive treatment, including medications. And that low threshold medication for opioid use disorder treatment represents a key link between episodes of illness driven by opioid use disorder and effective management of opioid use disorder. So in this talk, we'll be sharing the evidence regarding barriers to treatment access, effective medication treatment initiation, and lesson learned from the rollout of low threshold MOUD clinics. We'll identify some critical challenges facing patients seeking treatment for opioid use disorder, describe the treatment initiation process and best practices and what happens in the clinic on the first day, and describe the features and the team structure of a example low threshold OUD treatment clinic. We hope that after this talk, you're able to think about and implement some practices to reduce barriers to accessing MOUD treatment, to implement some procedures and best practices, initiating new patients and clients, and consider implementing the principles and practices of a low threshold MOUD clinic to reduce barriers to entering and staying in treatment. So a patient's first day, we'll start off with a little discussion about some of the barriers to getting to a first day in clinic when an individual has opioid use disorder. So we'll use a case. Mr. C at 18 graduated high school and started working as an electrician. He had a car accident around age 22 and his best friend died in that accident. He started taking oxycodone every night to get to sleep. The use progressed to using intranasally. He found that he was having trouble cutting back, and he did have his first overdose where he was revived by EMS with naloxone. Use continued. He found that he was not able to achieve the same effect snorting intranasally, and so he progressed to injection use. Less opioid was needed to achieve the same effect, and he found that he was getting very sick if he did not use continuously throughout the day. He began injecting daily and actually ended up developing an infection of the heart valves that's called endocarditis. He was hospitalized after that infection because of that infection for a while, and after that hospitalization, he went to a residential program. The residential program did not provide medication for opioid use disorder, so he went through withdrawal in the hospital, and then did not receive medication for opioid use disorder in the residential program, but he did not return to use for several months after leaving the residential program. He returned to daily heroin use after he started having worsening nightmares and anxiety. And then he decided that he wanted to try a different approach. And so he began to he entered treatment at a buprenorphine clinic, and he found that it worked really well, but the costs to attend the clinic were several $100s a month, and he just was not able to meet that cost. And so he stopped receiving treatment at that clinic, returned to heroin use, had another overdose and developed pneumonia, and was hospitalized again. And at that time, he met with the inpatient addiction consult team at the hospital and was initiated on buprenorphine during the hospitalization and linked directly to the UK First Bridge Clinic after discharge to continue medication. So this graph shows a model that is used to describe the opioid use disorder cascade of care. And it was based on the model of screening, diagnosis, linking to treatment, staying in treatment, and viral load suppression of HIV, actually. But the coordination of complex care for chronic illnesses like HIV is actually a useful model to think about the progression of care and the complexity of care involved in taking care of patients with opioid use disorder, which I know we have said over and over in Kentucky Open and other centers is another chronic complex medical illness. And so the cascade of care for opioid use disorder moves through from left to right. The presence of opioid use disorder that's not diagnosed, the diagnosis, a person engaging in care, a person beginning medication for opioid use disorder. And I'm sorry, this still has the old term MAT, but in this context, we can say medication for addiction treatment. And then retention in medication for opioid use disorder at 6 months and continuing abstinence, including medication. And you can see that right, as things are now, there's a large gap in the number of people that have opioid use disorder versus those that are diagnosed. And then the gap continues to become larger for those that are receiving medications and those that are retained at 6 months. In the case of our patient, it took 4 years for him to be engaged in care at all. And then a total of 7 years for him to be to receive opioid use disorder treatment with medication. And I'll reinforce that in this whole space, he's certainly at risk of a fatal opioid overdose. So the reasons that it is so hard to get into and stay in treatment for opioid use disorder are complicated and multifactorial. So this was a qualitative study that surveyed people with opioid use disorder accessing treatment. And there are a number of complicated barriers that were identified. And if we break those out a little bit, there are personal challenges and personal barriers. So there's a lot of fear and stigma about starting treatment, about going to a clinic that provides medications for opioid use disorder. People might have had bad experiences before in different forms of treatment and are nervous about trying again. People may not feel comfortable in group settings and feel that they're going to be forced to attend group. They may have preconceived ideas about the role of medication and treatment for opioid use disorder. And people may be trying to work or take care of kids and they can't meet the requirements that the clinic may have in terms of attending sessions at particular times. There are financial and structural barriers to accessing evidence-based treatment for opioid use disorder. People may have trouble with transportation, paying for gas. They may live far away from a clinic providing buprenorphine or an opioid treatment program providing methadone. And then this is a couple years old, but a graph that demonstrates the number of treatment programs that maybe are cash only in different states and then that accept Medicaid versus private insurance. And cash only spaces are common and very, very difficult for patients to stay in. There are clinic requirements that sometimes make it very difficult for individuals to get into and stay in treatment. They may have children that they need to provide care for. There are a lot of restrictions. The schedule conflicts with work. They have to attend a lot of counseling appointments before they're offered medication. Clinics may have wait lists, just a few examples. Or they may have other medical problems like high blood pressure or diabetes, and then they have to go to a different clinic to receive treatment for opioid use disorder. And the number of doctor's appointments adds up and becomes problematic. So these barriers are very complicated. And then of course, the result of them is also has many impacts. So 9 out of every 1,000 Medicaid patients carries a diagnosis of opioid use disorder, but only 0.5, half of every 1,000 patients receives medication. So that shows you that in just the Medicaid population, there's a huge treatment gap. Those that are in rural counties are significantly less likely to receive treatment than those in urban counties. And then for people presenting to an emergency room with a non-fatal overdose, 5.5% will die at 1 year. And these are very young patients, median age of 39. That is a high mortality for a patient population of that age. So I wanted to start this next section with a question. What all do you think should be included in a patient's first day in clinic? You can type into the chat or take yourself off mute if you'd like. So history, assessment, and education.
I think having a chance to spend a little bit of time with a peer support specialist, somebody with lived experience that can encourage them. I think that's, I think people have barriers at certain levels of until they get to know somebody. So somebody on their level that's done what they've done, that encourages them to put faith in the rest of the system, I think really does work. I see that every day.
Thank you. So someone's mentioning overdose education, absolutely. A mental health evaluation, yes. An assessment of barriers, and then a plan to address them.
I would like to add possibly, a clear outline, maybe the contract of the expectations, requirements of the program, because working within facilities, I've seen several patients have to drop out or in their treatment within, the first week or 2 weeks of receiving after enrolling in treatment, because they were not educated upon the requirements and such. So like Mike had added, troubleshoot the likely roadblocks to maybe address the barriers before they actually, so that they can find somewhere else that would work better for their schedule and needs.
Yep, that's a very good point. So we'll go through some of those issues with the treatment agreement. And there are some differences in terms of low threshold or medication first approaches, as opposed to being more strict about some of the attendance requirements if other things are otherwise going well, recognizing that patients' lives are complicated and it may be difficult to attend for multiple hours several times a week, for example. So discussion of harm reduction, different treatment options. Yep. And then referrals for additional services. So these are all really great ideas, and we're going to go through most of this. And initiate services. Yes, absolutely. Initiate medication on the first day if possible, if at all possible. We want people to come back, and we want them to reduce their risk of overdose. So absolutely. All right, I'll move forward. Thank you all. There we go. So initiating treatment will involve a comprehensive assessment and an examination. We'll go through a substance use disorder assessment using the DSM-5 criteria, the Diagnostic and Statistical Manual. We'll do a complete physical exam. We'll do an assessment of risk behaviors, including injection practices, with an eye to educate clients to help them stay safer, recognizing that most people do not immediately stop all forms of use in one day. And so part of good treatment is also recognizing that behaviors are complicated, and that we should do everything we can to help people reduce risk and stay safe. We'll do mental health assessments and screenings, assessment of the client's recent report of use and craving and withdrawal to address those in the treatment plan. We always ask about a history of overdose, and we do overdose education and naloxone distribution. If we can't give the patient a kit in that moment, we make sure to send the prescription to a pharmacy for the patient to pick up. But obviously, we always prefer to be able to hand the patient a naloxone unit in the moment. And we do a treatment history and review of records from any other providers with a release of information. And we have to review CASPR in Kentucky. That's the name for the prescription drug monitoring program, where all scheduled prescriptions that are filled at a pharmacy get entered into a central database. And it's part of the requirement to prescribe scheduled medications that we need to review the recent report from CASPR. And then we'll do urine drug testing in the clinic and do lab work, but lab work should not delay the initiation of medication. So this has been reviewed already in previous Kentucky Open, but just as a little refresher, the diagnostic assessment for substance use disorders is based on the DSM-5. There are 11 criteria. These apply to all substance use disorders, but we review essentially a lifetime history of use, and then go into diagnostic criteria for anything that has been used in the last year. And this can take a little while to go through with clients, but it's really important, particularly to diagnose opioid use disorder, and then to get a sense of other substance use disorders that may be present, to address those as part of the ongoing treatment plan, recognizing that we don't have effective medications at this time for the treatment of stimulant use disorder like methamphetamine or cocaine, but really it is more common that people have more than one substance use, and it's better from a treatment standpoint to understand all of those aspects of the client's substance use disorder. So the clinician should do a physical examination, specifically with an eye to looking for other chronic illnesses, any evidence of complications from injection drug use. It's another opportunity to provide education in terms of safe injection practices, have a conversation about referral to syringe exchange. patients may need referrals to other care like primary care or dentistry. If there are problems with teeth that are causing pain or infection. And then as part of the conversation about lab screening, talking about risks of viral hepatitis and sexually transmitted infections as well. And then in addition to talking about substance use disorders, it's important to have a comprehensive assessment of all the risk behaviors. So not only safer injection practices, but also safer sex and sexual risk. So we review in detail, we get into the weeds with clients about what are their injection practices, talk about all the details of equipment, the risks of sharing, and it's important to talk about the risks of sharing everything. So it's not just the needle and the syringe, but it's also the cotton, the spoon, the water. We want to make sure everybody's using whatever you use is just for you and not for everybody else, because you can transmit hepatitis C it is more easily transmitted on the cotton or the cooker, for example, than HIV. Talk about the risks of injection at different sites of the body, where is safer to try to go. And then we assess access to syringe service programs where clients obtain their supplies, and encourage people to access syringe service programs if they're not currently doing that. We talk about the sexual risks as well. Sometimes clients are engaged in transactional sex, and it's important to assess that because that is certainly a behavior that puts someone at risk for sexually transmitted infections like HIV, syphilis, gonorrhea, chlamydia. We inquire about the number of partners and condom use. We inquire about any HIV positive partners that they may be aware of, and then the history of any sexually transmitted infections, and we treat or refer to treatment. People who inject drugs are eligible for pre-exposure prophylaxis for HIV. The recommended eligibility are people who have any injection use in the past 6 months and any sharing of equipment, or the presence of a sexual risk and any injection use. And so this is for HIV prevention. I talk about this with my clients who inject drugs. And it's certainly recommended to help keep people safe and reduce the risk of HIV acquisition. It's important to do a comprehensive mental health history and evaluation. So we do a review of symptoms. There are standardized assessment checklists that the client can do in the waiting room before going into the room to meet with a provider or the counselor. We use the PHQ-9 or the Beck Depression Inventory, BDI. We also use the Beck Anxiety Inventory. We ask about the relationship of psychiatric symptoms to substance use, any prior psychiatric diagnoses. We also ask about a history of trauma. The presence of trauma is very common in clients with substance use disorder, and it's important to include that in the treatment approach, recognizing that it can be an important part of how someone may be about the reasons or the risks for their developing substance use disorder in life. And then any previous mental health treatments and response. Did they ever have inpatient or residential treatment for psychiatric or substance use disorder reasons? Any participation in an IOP or partial hospitalization and other outpatient treatments? And whether they had taken medications and whether they'd been effective for treatment of depression, anxiety, bipolar disorder. So you all recently had a Kentucky Open session targeted at naloxone and opioid overdose education. As a refresher, this is a very important section of the first day in clinic, is to make sure that people understand how to recognize and respond to an overdose and that they have access to naloxone. So if they, ideally, we can give a patient a naloxone unit at their first visit. If that's not possible, as I said before, we would write a prescription to send to the pharmacy for them to pick up. You want to review the risk factors of an overdose, how to prevent opioid overdose, things like not using alone, doing a test dose, using less than perhaps you would have if you're not sure there may be a fentanyl contaminant. Recognize signs of an overdose. What are the steps in responding to an overdose? Most importantly, calling 911, trying to rouse the patient, and giving naloxone. And then information on naloxone, how to give it and how to store it properly and safely. As part of the initial visit, clients will have a urine drug evaluation. So most clinics will have point of care testing. That's just a dip that's done in the clinic. What's important to recognize about these tests is that they're qualitative. So there are both false positives and negatives, and they need confirmation. This is not necessarily absolute. So we always ask whether what the recent use has been, and then if there are any discrepancies with our qualitative dip, we ask the client about it and then refer for confirmatory testing. If the client says, that's not right, or if there's anything that doesn't make sense. The lab testing that's recommended is a complete blood count, metabolic panel that includes testing for liver function, and a urine pregnancy test for anyone of childbearing potential. There should be HIV screening for viral hepatitis. That would be hepatitis B and C, and then screening for other sexually transmitted infections. As I said before, this lab testing can be done within a couple weeks of starting treatment. It does not have to delay the initiation of medication. The drug screening should include testing for opioids. That includes buprenorphine and methadone. It will also include morphine, oxycodone. THC would be cannabis, benzodiazepines, amphetamines, and cocaine. Unfortunately, gabapentin and alcohol testing is recommended in the Kentucky Board of Nursing regulations for APRNs that may be waivered and prescribing buprenorphine. I will say these are not available by urine testing qualitative. And so that would need to go to a lab for confirmatory testing. And alcohol testing is really not best done by urine testing. Alcohol testing is easily done by a breathalyzer, which is relatively inexpensive and can be done in the office. So as I said before, confirmatory testing for urine testing is the only option for fentanyl. We don't have an approved point of care dip test for fentanyl testing in the clinic. And it is more expensive and not immediate. So we recommend doing a point of care test. And then if there are discrepancies, or if the client says that's not right, then you can send for confirmatory testing. It's also a good idea to do some periodic confirmatory testing, which is a part of the Kentucky Board of Medical Licensure regulation, and also is the only way to screen for fentanyl, which is important in addressing risk with your client. So as we talked about in our what should happen, it's very important to discuss the treatment options as part of the first day. So even if they've been in medication treatment previously, it's very important to include a discussion about how the FDA approved medications work, and then a brief description of the differences between the medications. So these are excerpts from our MOUD flyer, which is a brief summary that's meant to be at a approximately 8th grade reading level. It describes the 3 different FDA approved medications and summarizes the differences between the 3. So these here are 2 graphics that we include on our flyer. And if you all don't have the flyer, we'll be happy to send it to you. It uses the analogy that the opioid receptor in the brain is like an outlet, and opioids plug into that outlet and stimulate the outlet. Methadone is like a regular plug that fully activates the receptor. So it fits in the outlet really, really well. The plug fits perfectly in the outlet, and also it allows maximum current. So what that means is that there's no ceiling to the amount of current that can flow between the outlet and the plug. Buprenorphine is like a plug and a power strip. So basically, the fit is the same. The fit is perfect with the receptor, with the outlet. The plug fits perfectly, but there's a power strip. So there's actually a ceiling of the amount of current that can go through. And that's why it's called a partial agonist, because there's a ceiling in the amount of stimulation that can go through that receptor. Then the third medication is naltrexone. It fits perfectly in the outlet, but you'll see there's no cord. So there's no energy that can flow through. It's a total blocker. Now, what's important also to know is that at therapeutic doses of methadone and buprenorphine, it's not like just one thing is plugged in. The majority of the outlets have a plug in them. So that means that if another opioid comes along, if a client has a slip, for example, that other opioid won't be able to unplug the methadone or buprenorphine or naltrexone from the receptor. And so the person is relatively blocked and doesn't feel the effect of the other opioid. And so that diminishes the likelihood of trying again, because there's nothing particularly rewarding or reinforcing of using the heroin when they have a therapeutic dose of methadone or buprenorphine on board. This little chart here summarizes, so this refers to methadone. It's depicted by a little cup because most of the methadone and opioid treatment programs is liquid. Buprenorphine is both strips or films, and then there's a monthly injectable form of buprenorphine called Sublocade, and then extended release naltrexone, the brand is Vivitrol, is available only as a monthly injection. And then both methadone and buprenorphine treat withdrawal. Both methadone and buprenorphine decrease cravings and treat pain. There are data that demonstrate that they reduce infections like HIV. They are associated with reduced rates of crime, and they are associated with reduced mortality. We know that both methadone and buprenorphine treatment reduce the risk of death significantly by about half. Naltrexone does not treat withdrawal or pain. We do not have data on whether naltrexone is associated with reduced risks of infection or death. And it's plus or minus whether naltrexone decreases cravings. It seems that for some people it may decrease cravings somewhat, but that's not universally true. And then what's really important is that going through withdrawal is needed before starting naltrexone. So a person can't use any opioids for about 7 to 10 days before beginning extended release naltrexone. And that is not the case for methadone or buprenorphine. For methadone, you can initiate right away, even if you used heroin that day. And for buprenorphine, there's usually a period of mild to moderate withdrawal, about 8 to 12 hours from the last opioid use. Okay, so I think Abigail asked about the treatment agreement. It's very important to review with clients both the expectations for the provider in providing treatment, and then the expectations for the client in receiving medication treatment for opioid use disorder. The treatment agreement, that's an example here. You can point your camera on your phone on the QR code and it'll show you a PDF of a sample treatment agreement that is at pcssnow.org. Essentially, it reviews the expectation that the medication that is being prescribed is for you and not for other people, that the way it's supposed to be taken, that you should follow the recommendation of your treatment provider. And if you have, if you think that you need more or less medication, that's a conversation to have with your treatment provider. It describes that urine testing is part of treatment. It describes that there may be recommendations for additional treatment intensity if it seems that the person is not doing well, and that there may be closer supervision if it seems that maybe the medication is not being taken as prescribed or not being taken correctly. It describes that it asks people, please don't engage in any violent or threatening behavior in clinic. And it asks people not to come to clinic acutely intoxicated. One of the key factors of low threshold clinics is that we are medication first, which means that if a client is, we recognize that the medication saves lives, and we try to do everything we can to help people stay in treatment because we know that that's more likely to help people be successful long-term. So if people's lives are complicated and they're not able to attend all of the counseling sessions that we might recommend, but they are taking their medication appropriately and seem to be progressing, there's less opioid use than before, and things are otherwise seem to be going well, patients can certainly continue to receive medication. So if there's time in the initial visit, we like to review goals with clients. So both initially, there's a real focus on short-term goals, maybe your goals within a few days to a couple of weeks. And then as people progress in treatment, there may be more of a focus on medium to long-term goals. Maybe it's, employment related or family related goals that people might be setting as part of their progression in treatment and entering long-term remission and recovery. This is again an example. This link will go to the large treatment improvement protocol, tip 63. It's a very large document. There are a number of helpful tools at the end of the document, and an example of a goal setting sheet is on page 168. Again, in the first day of clinic, there should be a brief discussion of recommendations for counseling. This should be tailored to individual clients' symptoms and their individual needs. It's important to recognize that the medication management, the standard medication management of providing buprenorphine treatment by the physician, nurse practitioner, or PA includes basic counseling. So basic counseling is absolutely part of our provider visit. So if there's going to be additional counseling on top of that recommended, being introduced to the counselor or discussing future session appointment times is certainly ideal. And for my clients, for example, that I think would benefit from counseling, but additional counseling, but maybe they are reluctant at the time, I might do an initial introduction, ask that they meet with the counselor at least once, and then readdress periodically as treatment goes on, depending on how the individual person is responding. And it may be that if they're not open to it in the initial visit, they may become more willing over time as potentially some other aspects of their life become more clear that they would like to be working on. So taking our case into the UK First Bridge Clinic, some of the things that patients are looking for, and this was again a qualitative survey done with clients with opioid use disorder, is that the clinic is low threshold, meaning that it meets the patient where they are. I can come here at any time. It's especially beneficial when they're experiencing social and financial difficulties, like unstable housing, or maybe the inability to pay for transportation if they're just getting a ride from someone or relying on limited public transportation, or if they're incarcerated. That there's flexibility in the treatment approach, so that clients aren't forced to engage in specific groups or counseling sessions, and that the patient and provider work together to decide on the best supports for that individual client, and that there's a focus on harm reduction. So this being non-judgmental and recognizing that being able to have open, non-judgmental conversations about complex behaviors that put individual people at risk are really important to helping people feel safe and feel that then they're able to share what questions they may have about staying safe and staying alive. So our first Bridge Clinic launched in January of 2018, and it was supported initially by SAMHSA funds, which are awarded to the state through the CURES Act. It was a partnership with the Kentucky Cabinet of Health and Family Services and the Center on Drug and Alcohol Research and UK Healthcare. The primary goal of the First Bridge Clinic is to save lives. So it connects individuals to treatment who presented to the emergency department or hospital with complications of opioid use disorder, like overdose, withdrawal, abscesses, severe life-threatening infections like endocarditis. And it provides on-demand access to evidence-based care and decreases obstacles to care. So the goals are to stabilize the patient, provide wraparound ancillary services, and ultimately bridge them to treatment in the community. So Mr. C left the hospital and began treatment at the First Bridge Clinic. He met with the patient relations assistant who reviewed his insurance information, collected a small copay, obtained a release of information to collect records from previous care, and coordinated care with his other medical providers. Our nurse navigator, Becky Tarr, reviews the flow of the clinic visits and the treatment agreement with Mr. C. She delivers a naloxone kit and provides safe injection education. She gathers his vital signs and the urine drug screen and collects the report from Casper. The physician or nurse practitioner completes that comprehensive medical evaluation, discusses the options for medication treatment of opioid use disorder, and this patient decides to continue the buprenorphine he started in the hospital. The provider will look again at the treatment agreement and adjusts. For Mr. C, he'll have counseling recommended once a month. And then the provider writes a 1-week buprenorphine prescription. Mr. C met briefly with our counselor, Kelly Ruff, to introduce her role. And then on future visits, he'll have a separate check-in with the counselor. Kelly does mental health assessments and facilitates both group and individual therapy. And then Mr. C also meets with our peer support specialist, Alyssa Fox. So she meets with him briefly to introduce her role. She does a recovery capital assessment, delivers motivational interviewing, shares harm reduction strategies, and facilitates mutual aid groups. And Alyssa continues to be a contact for Mr. C going forward in treatment. The clinic manager discusses and troubleshoots any issues with filling the prescription at his preferred pharmacy. And then they begin, since Mr. C lives pretty far away from Lexington, they begin a conversation about some clinics that may be available closer to his home that he'll consider when he's stabilized and doesn't need to come to Lexington anymore for medical appointments for follow-up of his recent infection. And then he has his follow-up appointment scheduled and also gets a referral to a primary care provider, which he hasn't had for a long time. So after his first day, what did Mr. C leave with? A buprenorphine prescription that would cover him until the next time he could return to the clinic, an appointment with the counselor the next week to discuss some PTSD symptoms, the phone number of the clinic's peer support he can call for support or resources, a new appointment with a primary care physician, a naloxone unit, and information on safe injection practices that can be shared with a friend or loved one, and the beginning of a plan for achieving remission and long-term recovery of opioid use disorder. So over time, Mr. C started in October at the First Bridge Clinic. In November, he had some increasing in cravings and having some worsening PTSD symptoms. And so the number of the counseling increased. And then in December, things were kind of stabilizing. He returned to work and began saving for his own apartment. In January, he had a big argument with family, and that triggered a slip and return to some opioid use. And so that meant that visits increased frequency. He had the need for some more visits. And actually his dose of buprenorphine was increased a little bit. And then in February, he stabilized back out again. Cravings were better controlled. He was attending some groups with the peer support specialist, and he was able to restart work. In April, he had actually another surgery for the heart infection that he'd had, and that went very well. And then by May and June, he established care with a new primary care physician in his community who was also able to prescribe buprenorphine. And so 6 months without any other opioid use, he bridged out to continue buprenorphine treatment in his primary care clinic. So to bring us back to the cascade of care for Mr. C, from diagnosis of opioid use disorder to being retained in treatment for 6 months took a 9-year period of time. But throughout all of this, he remained alive, which is really what's so critical. So if we don't keep people alive during this period of time, they have no chance to get better. And so I think it's important to keep the long-term perspective and remember that when people are struggling, they are struggling in that moment, but they are certainly have a very good chance of getting better. And so we stick with people during the ups and downs of treatment. We don't have a perfect treatment, but the treatment that we do have with medication is very good at keeping people alive. And so we work with people long-term, trying to remove barriers and help keep them safe so that ultimately they can enter long-term remission and recovery. So this is just a representative quote of someone who is accessing treatment in a low threshold clinic. They treat you like you're a person and trying to make your life better, encourage that. And I think that's an awesome thing instead of not believing that you can even. So that's our wrap up of the patient's first day.